Okay, I think we should get started. We're at the top of the hour. First of all, welcome everybody. My name is Megan Dotson, and today our webinar is going to be on understanding American Indian postpartum care and cultural considerations with our special guest speaker, Avis Garcia. So we're glad to have Avis back with us. This is a map, and it's brought to you by the MHTTC network, and we're part of the American Indian and Alaska Native Mental Health Technology Transfer Center here in Iowa. This is a map of all of our partners in the TTC centers across the country, HTTCs, prevention, and mental health. So our project today is funded by SAMHSA, and they support us by a grant. The content of the event is the creation of the presenter, and the opinions expressed do not necessarily reflect the views or policies of SAMHSA, HHS, or the American Indian and Alaska Native MHTTC. This webinar is geared towards the Federal Initiative for Perinatal Care and Postpartum Depression for American Indians and Alaska Natives, and I've included some resources for you guys, and you will receive this in your follow-up email, so don't feel that you need to write them down now, but just wanted to include these in your handout packet following this webinar. And another page that goes to the National WIC Association, and then the strategies to address national mental health crisis that was recently released. So you have links to those. Following today's event, you will receive a follow-up email, and that'll include links to the presentation slides and recording, which we are recording this, information about how to request and receive CEU's certificate of attendance if applicable, and links to our evaluation survey called GIPRA that we ask that you fill out towards the end of the event. Okay, and so I'm going to read this land acknowledgement. We would like to take the time to acknowledge the land and pay respect to the indigenous nations whose homelands were forcibly taken over and inhabited. Past and present, we want to honor the land itself and the people who have stewarded it throughout the generations. This calls us to commit to forever learn how to be better stewards of these lands through action, advocacy, support, and education. We acknowledge the painful history of genocide and forced occupation of Native American territories, and we respect the many diverse indigenous people connected to this land on which we gather from time immemorial. While injustices are still being committed against indigenous people on Turtle Island, today we say thank you to those that stand with indigenous peoples and acknowledge the land reparations must be made to allow healing for our indigenous peoples and to Mother Earth herself. And this land acknowledgement was actually created by 3 of our staff members here, Ella Driscoll, Keeley Driscoll, and Sean A. Bear, the first part of the Meskwaki Nation, which is the settlement in Iowa. So with that, Avis, I'm going to let you introduce yourself, and I'll stop sharing my screen. You know yourself best. So welcome, Avis, and thank you so much for doing this today and being with us.
Okay, thanks. I don't know why I have this bright light behind me that's going right through my picture.
We can see you quite well.
Okay.
Hopefully you can see your computer screen.
Okay. Yeah. Just a little about myself. I am currently the Director of Clinical Services for the Absalakai Healing, that is the Crow Tribe Outpatient Substance Abuse Treatment Program Center. I've been here since June. I am an enrolled member of the Northern Arapaho Tribe. I come from the Wind River Reservation in Wyoming, which is just a few hours away from here. I have earned all of my degrees from the University of Wyoming, and I have a PhD in counselor education. I am a licensed addictions therapist and licensed professional counselor in Wyoming. And here in Montana, I am a licensed addiction counselor and a licensed counselor, professional counselor. It's a different name, but I'm dually licensed in both states doing mental health and substance abuse work. I've been in this field for 20 years now, and I've worked on the reservation and off the reservation, and sometimes both at the same time. And while I was in the end of my doctoral program was when I connected with the ATTC in Iowa, and I've been there with this program for a couple of years now. And I often do webinars specific to American Indians. And, I always put questions out there for the audience, if there's ever anything you're interested in learning more about, I'm always willing to do the research, which is what I did on this presentation that I'm doing today. So today we will be covering postpartum care and discuss some cultural considerations. And I always like to preface my presentations by letting you all know that I am someone who doesn't want to disrespect other cultures, knowing there are 567 federally recognized tribes in this country alone. And I, being Northern Arapaho, view things differently than other tribes might do. And we had that discussion this morning here in our morning meeting, because I have brought on a cultural counselor who kind of is my guide here, so that, I'm being respectful of their ways and beliefs here where I'm at. So I just thought I would add that. We'll go on ahead and get started on today's presentation. Because this is on postpartum care, the emphasis is going to be on postpartum depression. And so usually the weeks following childbirth for most women are usually filled with positive thoughts and emotions. And women with postpartum depression don't have that experience. It's often negative thoughts and emotions that can consume their daily lives. So it was really interesting to delve into this research on this project. So let me get to the share screen so that I can pull up my slides.
Okay, go ahead.
Okay, so we're just going to go on ahead and get started with this presentation. Understanding postpartum care and cultural considerations. Oftentimes, the weeks and months following childbirth are filled with positive thoughts and emotions, yet women with postpartum depression have negative thoughts and emotions that can consume their daily lives and also has a significant impact on their partner and the family. Okay, now why is this? Okay, let's switch it here. Introduction. And I don't know if these are the right slides, because I have objectives and the objectives aren't, oh, here they are, sorry. The objectives that I'm covering today are the definition of postpartum depression, identifying risk factors of postpartum depression, and we'll just say PPD from here on out. Identify some screening tools and protocols and discuss the impact of PPD on the mother, child, and family. Identify the cause of PPD, explore interventions for PPD, discuss cross-cultural factors, or cultural factors from an American Indian viewpoint. I always like to preface my presentations in saying that I don't speak for all Native Americans. There are some generalizations, but when we have over 560 federally recognized tribes, there are differences. And as I've gotten older and traveled around the country and worked with different people, I see similarities, but then I also see differences. So when I share what I'm sharing, it comes from my life and my experience as a member of the Arapaho tribe. I am also part Shoshone, and I see clear differences in that, but like I say, being enrolled Arapaho and being raised that way, that's how I identify. And it's been interesting to talk to other natives who are more than one race, because in today's world, it's rare you run into a full-blooded any tribal member, because there's so much intermarriage between the different tribes. And I noticed that a lot of those, well, my son would be an exception because he's enrolled Shoshone, but he identifies as Arapaho because he practices those ways, of course. So even though somebody might be 3 or 4 different tribes mixed together, they usually pick one that they tend to use as their base of their foundation of how they go about living their life. Anyway, just a little bit on that. The introduction, postpartum depression usually occurs in the first 4 to 6 weeks after giving birth, and it is unlikely to get better by itself. 50% of those with PPD can experience depression for more than a year after childbirth. So some of this information that I did research on was a bit surprising for me, and that was one of them that really stood out. Like, you know, as a mental health counselor and a substance abuse counselor, I never really thought to really further explore if maybe this, you know, yeah, they might be presenting with depression, but did we specify that it's postpartum? Women who are not receiving clinical treatment, there's a typo there, sorry. It should be 30% of women with PPD were still depressed up to 3 years after giving birth. So, I mean, see, not just a year, but 3, that's a significant amount of time. 14 to 29% of PPD prevalence rates in American Indian women. So that is like the average rate of the Native American women based on research that present with PPD. To further define PPD, I've heard some people, you know, talk about it as baby blues, and you know, it's not good to minimize what's going on with the person who's struggling with it. We don't want people going, you know, without treatment, and it can be damaging to the bonding and the attachment between the mother and the child. So it's good to let them know that, you know, we're here to help. So prenatal mood disorders can occur at 20 weeks gestation to 4 weeks of age. According to the CDC, up to 20% of new mothers experience symptoms of depression. So CDC, this is all mothers. So that's quite a big number there. Postpartum blues is a relatively common emotional disturbance with crying, confusion, mood lability, anxiety, and depressed mood. Symptoms appear during the first week postpartum, last a few hours to a few days, and have some negative sequelae. Talking about the culture-bound syndrome, this came up in some of the research that I was doing on this topic. And this term came from the field of psychiatry and anthropology. So sometimes, even though I'm trying to be specific in getting information on a subject, it tends to bleed over into other areas that I haven't considered. This is considered to be some deviation from mental health or psychological norms. It is cross-culturally recognized. In some cultures, it is viewed as an illness or a disease process, and in others, it is perceived as a normal variation of transitioning to a mother role. So not being able to get more specific on other Native tribes, like I told you, I think I narrowed down today's presentation on 3 articles of what I was able to find. And there are some tribes who do believe when women, or not just women, but anyone in general, is struggling with what maybe seem out of the norm, that there could be some witchcraft or some kind of outside forces causing these things. So we always have to be mindful of what tribe you're working with and how they handle those situations. And like I said, I can only speak from where I come from of how that might be addressed, because each tribe has their own ways of dealing with certain things. But it generally centers around the family getting involved. It's real important to have a family be involved and be supportive as much as they can. The DSM-5 now uses cultural concepts of distress to describe how emotional distress is experienced. and understood among cultural groups. So I am really surprised that now that the DSM is starting to open up and take into consideration that cultures view things differently, and that, you know, just because they say this is how some disorder is, that's how it is for everyone, without looking at the cultural aspects of it. At the other end of the spectrum, postpartum psychosis refers to a severe disorder beginning within 4 weeks postpartum. Can include delusions, hallucinations, and gross impairment in functioning. So this can get really serious and dangerous. So it's good to be aware of these issues that can come up. PPD begins in or extends into the postpartum period, and core features include a dysphoric mood, fatigue, anorexia, sleep disturbances, anxiety, excessive guilt, and suicidal thoughts for at least 1 month. So this is a severe depression. The DSM-5 requires us to specify at least 5 of the following symptoms must be present nearly every day in the same 2-week period and represent a change from previous functioning. So this is going to come from people that know that person, of like, they've noticed a significant change in that person's behavior that you might be concerned about, the identified patient. That's what we often refer to them as. The DSM-5 diagnostic criteria: 1, significant weight loss when not dieting, or weight gain or increase in appetite. So it's either or. Insomnia or hypersomnia, so they can't sleep or they're sleeping much too much. Psychomotor agitation or retardation, fatigue or loss of energy, feelings of worthlessness or excessive or inappropriate guilt, diminished ability to think or concentrate, or being indecisive, and recurrent thoughts of death, not just the fear of dying. And so you always want to screen the recurrent suicidal ideation with to see if they have a specific plan, if they've made any attempts, or, you know, that's how you're able to determine how much support this person needs. Because some people, it may just be thoughts, others may have already been contemplating how they would proceed with that. So that lets you help with the assessment on that. So we always have to be mindful of that. I have, from personal experience of being in the field for 20 years, I have encountered people who now I see their mothers probably had postpartum depression, and at that time nobody knew, and they did result in suicide. I've even had men come to me for counseling. These were usually non-native men who their wives were clearly presenting with postpartum depression. And these were like, now that I'm going over this presentation, I thought, it was so good for me now to see those men coming in for counseling for themselves, of like, my wife is going through this and I just don't know what to do. You know, like everything I try to do to help her, she pushes me away. She doesn't let me, you know, try to be any help. So we often don't stop to think about the father of the child who, you know, wants to be helpful, of course. So I think some information needs to focus on the men in this. Postpartum psychosis is a rare illness compared to the rates of PPD or PPA. I also learned in doing this research that not only do we have postpartum depression, but we can also have postpartum anxiety. It occurs in approximately 1 to 2 out of every 1,000 deliveries. The onset is usually sudden, most often within the first 2 weeks postpartum. Sorry, I'm seeing these typos as I'm moving on here. I'll have to go back and fix those. The most significant risk factors for postpartum psychosis are a personal or family history of bipolar disorder or a previous psychotic episode. So it's important to get that background information. Symptoms of the psychosis is delusions or strange beliefs, which are egosyntonic. And egosyntonic means it's obviously clear to us that what this person is believing and saying is not true, it's not real, but they believe it. So that's a clear warning sign right there. hallucinations. They could be seeing and hearing things that are not there, feel irritated, have hyperactivity, a decreased need for or an inability to sleep, paranoia and suspiciousness, rapid mood swings, and difficulty communicating at times. Infants' attachment to the mother is very important, and not being successful can lead to long-lasting negative consequences for the child in the long run, such as being insecure or disorganized attachment and mother-infant relationship can lead to childhood aggression. And like I said, being in the field as long as I have been, I also know that children who are raised by caregivers who have serious mental health disorders, it really causes a lot of problems for the children. And I think when clinicians are dealing with these parents and caregivers, that they don't realize that this is really traumatic for the kids that have to live in that situation. So just to expand on that, so it can get really complicated. The disorganized attachment during infancy has predicted psychopathology in late adolescence. So if, sometimes when we do these clinical intakes or clinical assessments, we do ask a lot of questions like about when you were born, how were things as you were being raised. And, some of these kids, especially in kids that are adopted, I know have a lot of problems because they don't have that natural bonding with their biological parent. It's going into, a whole different environment for them, which is also complicated. Some of these scary thoughts that comes along with the postpartum psychosis and depression is these scary thoughts are a very common symptom of PPD. Scary thoughts can come in the form of, what if I hurt the baby, or images imagining the baby falling off a changing table or the bed. Scary thought can be indirect or passive. Something might happen to the baby, or they can imply intention, thoughts, or images of stabbing the child. These are the real severe cases. And I know we all see the news stories of, some women maybe have taken her, her own children's life, but do we stop to think what was really going on with that woman? It was, severe psychiatric disorders. Scary thoughts are not an indication of psychosis. Scary thoughts can be a part of postpartum OCD diagnosis or PPD. So there is also postpartum OCD, the obsessive compulsive disorder. And this is with the mom who wants to do everything just perfect and nobody else can do it. Like they won't let anyone else do it because they don't think someone can help them. So that was another thing that I learned here. And I was like, there's more to just postpartum depression. It can be very complex and broad. The hallucinations that they have are not command hallucinations. They may need a short course of medication. The mother needs help to not distance herself from the child. Keep an eye out to make sure that she doesn't become egocentric. So that's making sure that she's in touch with reality. And if she's not, that's a serious red flag. Have them keep a journal. The fact that these thoughts are scary to you is a normal reaction, is what, we should let them know, don't be worried about it. It's perfectly normal. And women won't volunteer this information because they're also afraid we might take their child away or something might happen to them. So it's being very understanding and supportive of these women so that they don't feel like they have to hide anything, which can only make things worse. Symptom presentation in PPD appears as a predominance of obsessional thoughts concerning harm to the infant, as opposed to contamination, hoarding, counting, somatic or symmetry and ordering obsessions and compulsions. Terrifying thoughts that they are going to do something wrong. If I do XYZ, then maybe I won't have these thoughts or feelings. So these are the OCD characteristics. So they may think they need to do all these certain things in a certain order or a certain way. Again, that may require medical intervention or psychiatric intervention. Scary thoughts will make the woman feel like she's a bad mother. They will make her feel guilty and ashamed. It's a good sign if these thoughts are worrisome. Remind her that these thoughts are not about who she is or her capability as a mother. She, might want to have some affirmations for herself to help herself cope during this time, such as I am a good mother and I love my child, but not distancing themselves from the child. They need a lifeline or a connection to feel safer. So anybody, it could be their best friend. It could be maybe there's home visiting programs in your area. It could be the husband or a partner. We need to be able to help families navigate how this happens and just how common it is. I'm a grandmother, and I have a daughter who has my 2 grandchildren, and I seen her go through some serious, it was postpartum depression, and my granddaughter was born with microencephaly, which was her brain was small, so she had these like all these problems weren't even known until the baby was born. And so I was fortunate enough to be with my daughter throughout most of it. But after she was ready to be released from the hospital, after reading all of this, I'm just glad I did what I did. I literally had my daughter move in with me with her baby and the father of the child, because I was just that concerned. Because when I had my own children, I had my mother. It's traditional in the Arapaho way for the grandmothers and the mothers and the aunts to all be involved. So knowing that my daughter needed me then was very important. So as I was reading all of this stuff, I was like, I'm so glad I was there for her, but I saw just how hard it was for her. And I know someday she'll probably be a grandmother herself, but it's that traditional way of looking out for our grandchildren. And that is, in my tribe, that is our role, is to help with that as a grandmother. So the nature of these scary thoughts typically focuses on the baby, but can also center on thoughts about you or your partner. Scary thoughts can be intermittent or constant. They may be accompanied by compulsive behaviors, such as constantly checking on the baby to make sure they're breathing and they're okay. Some examples that's very severe is this, I might take one of the knives and hurt the baby. And this has just come from the research that I've done of giving me examples that I'm trying to provide. I can picture myself driving off the road with the baby in the car. I think my family would be better off without me. I can see terrible graphic things happening to my baby. And as I'm reading this, I'm just thinking about something that happened in this area recently of a young mother having a car accident with her baby in there. And I'm like, what was really, what was going on there, not knowing these people, and then reading stuff like this just kind of opens my mind to other things that maybe people hadn't thought about. These can be constant and terrifying. We need to help her develop a sense of safety, like asking her, what can you do? One suggestion would be to having them distract themselves, encourage moms to do something to feel safe, calling a friend, talking to a friend, making a list of things that they can do when they have those scary thoughts, asking them, what can you do to help yourself feel safe? If you have this fear, what can you do to help yourself feel safe? And let yourself know that the baby is going to be safe. You could go to a neighbor's house. You could go for a walk outside, calling a friend on the phone. Just don't leave these people alone with those thoughts, and let them know how important it is to know when they need to reach out and use some skills to help them manage those difficult times. Some possible interventions would be focusing on thoughts that empowers them. That doesn't mean they're a bad mother. Encourage them to get coffee or a drink that they like. If it doesn't go away, let them know, they're not always going to feel that way. And we need to destigmatize taking medication if it's needed. And I often say that with some of my clients that come into substance abuse treatment. I let them know this might not be ongoing. It could be, but it's real important to, at least try the medication to see if it helps with symptoms that they might be having. Practicing radical acceptance, practicing mindfulness exercises. Yoga is a mindfulness exercise. Reminding yourself that you won't always feel this way, that this is a challenging time, but it's going to pass. Some intervention would be encouraging the patient to tell someone she trusts how she's feeling and let them reassure her that she'll be okay when she gets the treatment she needs so that she feels she is loved and safe. If she feels that her thoughts are out of your control or that she cannot manage the intrusive, make a referral to a perinatal specialist, a psychiatrist, or call 911. If the woman's thoughts are worrisome to you, but she feels that her thoughts make sense and everyone else is the crazy ones, this is psychosis. So this is serious psychosis. And if it's an emergency, she needs to be evaluated by a psychiatrist or a physician immediately. There are treatments you can get to help them with this, and you need to let them know that you're there to support them. And there is an increased risk of suicide if she feels completely out of control. So we need to be mindful of that. Any questions? What types of things trigger postpartum depression and why? And you'll be surprised. Women who have experienced PPD have a 50% to 62% risk for future depression. There may be a history of mood disorders, premenstrual mood disorder, depressive symptoms during the pregnancy, a family history of psychiatric disorders, stress factors such as negative life events, lack of support or poor marital relationship. And I've often encountered several young women who were single and dealing with that pregnancy on their own. And I can't imagine how difficult that has to be on top of having a baby. Having a special needs or a medically fragile infant. And this is what I was talking about when I was talking about my daughter and having to watch her go through all of that. It was very traumatic for me, as a grandmother to see that. So this does affect the family. Substance abuse increases the risk, eating disorders, and family dysfunction. So all that stress just creates a lot more stress and depression, and it can bring anybody down. Some more risk factors, some more prominent for the partners. So this could be the father of the child, changing roles and responsibilities, feeling excluded when the attention is on the new baby, missing their sexual relationship with their partner, feeling overwhelmed at the financial and care obligations. Other children may feel abandoned, jealous, or resentful of the new baby, which can add additional stress and guilt to parents. And when I read this, I kind of laughed a little bit because I remember when my aunt had my two little cousins, the little boy cousin, when she brought the baby home, my little boy cousin told her when was she gonna take that baby back? And he was just, letting he this baby's taking all of my attention. Can you take the baby back where you brought it from? If it was possible. I never forgot that he did that. And, the changing duties and getting less attention. So kids feel that they're getting left out. So we want to minimize as much stress as possible. Make sure that the mother and the family have good support. It doesn't matter who it is, they just need support. I know back home where I come from, the Catholic Church, the father and the sister, I don't know about now with the COVID, but they often went out into the community, and just someone like that would be helpful for someone. Help them come up with a plan for the first few weeks after the baby is born, like preparing ahead of time of like, this is how we're going to get, the house is going to get clean, the meals are going to get done, all there's just so much involved. Men also need to get support after having the baby as well. I also discovered in this research that men get postpartum depression because their hormones also change when the baby comes home. Most of the research has been done on women, so we don't even recognize what's going on with the male partner. And, just reading this lets me know there's probably a lot more that we're so focused on ourselves as mothers when we're having our children that we don't even stop to think of what the partner is going through. The impact of postpartum depression disorder is prenatal. It could be inadequate prenatal care, not going to their appointments and taking care of themselves right, poor nutrition, especially younger people. I know they like to eat a lot of fast food, a lot of junk food. So it's important that they realize they need to be eating healthy meals. Higher preterm birth weight, low birth weight, preeclampsia, and spontaneous abortion, all of these can contribute to postpartum depression. The infant's behavioral problems can be anger and distancing, averting gaze, such as it's also known as a protective coping, passivity and withdrawal, poor self-regulatory behavior, dysregulated attention and arousal responsiveness, and cognitive and lower cognitive performance. So this has a big impact on infants that I didn't even realize was that serious until looking into this a lot further. The impact of postpartum depression in the infant: socially, mothers with PPD display less sensitive behavior towards their children, such as singing songs, reading books, and playing games. And this is where I think these home visiting programs would come in really nice, of encouraging moms to spend time with their babies and possibly even play therapy. When I was last at the University of Wyoming, they were starting a program where they brought couples in with their babies, and like you just put the little quilts on the floor, and we're basically just teaching the parents how to do play therapy with their own babies, which I thought was really neat because they brought the mother and the father in. They could be less responsive and attentive or nurturing manners, so we need to be paying attention to that interaction. Withdrawn behaviors inhibit the formation of a caring, attentive primary attachment. So if the mom is struggling, she's not able to give that attention that that baby really needs. So it's being able to encourage her to do that and support her doing that, and then getting another family member in there maybe that can, help facilitate that process. The attachment relationship also suffers from a lack of physical touch. And if those of you remember Psychology 101 or 1000 now, they do share research studies where they've studied the monkeys and the substitute babies and how that affected just, primates. So that bonding is really important. So they suffer from the lack of physical touch, which is crucial to the development of the children's regulatory skills and the ability to cope with stress. So having that bonding attachment with their parent is extremely important to their overall development. Some of the impacts on the toddler: behaviorally, there could be a passive non-compliance, a less mature expression of autonomy, internalizing and externalizing problems. They may be lower interaction, like less interactive with other people. And it also affects them cognitively. So they could have less creative play and problem solving abilities, lower cognitive performance. And the school-age children with postpartum depression, behavioral could be impaired adaptive functioning, internalizing and externalizing problems, affective disorders, and conduct disorders. So this is when kids start acting up. This is what I mean. If this happens early on, this could be part of that attachment disorder. Academic, attention deficit and hyperactivity disorder, and lower IQ scores. So as I was looking at all of these and all the work that I've done throughout my life, because I have been a school counselor as well at one point, and seeing some of the kids that I work with makes me wonder now to look back and be like, well, I wonder if mom had some postpartum depression or some mental health stuff that affected this child. Screening for postpartum depression, all women should be screened, even if it's not a first pregnancy. New fathers should be screened as well. One of the popular tools that I wasn't able to pull up, but I know it is available online for free, that you can pull it up. It's called the Edinburgh Postnatal Depression Scale. The research that I did read constantly pointed this one out in particular, but you could also use, the Beck Depression Scale. Just screening for those depression symptoms is important. Maternal mood is the immediate postpartum period, or up to 2 weeks postpartum, is a significant predictor of PPD. So also watch for an upsurge in symptoms after discharge. And, now that I think back when I had my children, I don't think anybody was even asking me of stuff like that. So those of you that are working with couples or anyone who's expecting a baby, you might want to, focus on that. And I never really thought of prenatal care, including mental health care. There may be an increased anxiety or decreased sleep. So it is very stressful to have a baby, even though it should be a happy time. It can be a huge adjustment. And I do know when we assess stress, that all of the factors that are listed, having had a new child, is like on that list. 73% of women who meet criteria for PPD screened in one study denied feeling sad. The reason why they would deny feeling sad at all would be embarrassment or fear of being judged, and also having a lack of education about the negative impacts of PPD on their child. So I think if they knew why we need to screen and that it's for the benefit of their child, that they might be more open to sharing whatever information is needed. Other causes could be hormone changes after birth and stopping nursing, a lack of sleep, pre-existing anxiety or depression issues, history of abuse or neglect as a young child, maternal chronic illness such as lupus, fibromyalgia, diabetes, Lyme disease, chronic fatigue, diabetes, like a whole host of problems that can add to postpartum depression. Poor control of diabetes can cause symptoms that look a lot like depression. So women that are diabetic and pregnant have like that much more to be concerned about, which I wasn't aware diabetes affected them that way. More causes of PPD could be trauma and grief. This could involve a miscarriage or a stillbirth, premature baby, birth defects, C-sections, and lactation difficulties. Also, a huge one that continually popped up was a lack of social support or intrusive social support. So they might not have the support they want, or people that are trying to give them support that they feel is intrusive and not helpful. Prevention and early intervention for clients at risk. Work with the woman and family during pregnancy to optimize mental health for all. Increase personal awareness of stress levels and effectiveness at dealing with stress. Prepare for the new addition, address any concerns, and develop a postpartum plan. Encourage breastfeeding or combo breastfeeding and pumping for late night bottle feeding. Prevention and intervention, weekly interactions, check-ins with a counselor to identify mental health and self-care needs of both parents. And I actually piloted a program based off a program that was run in Hawaii called Best Beginnings. And they screened people who might be at risk for child abuse, neglect, and abuse, and used those criteria as a list. And it was a home visiting program. So I was actually supervising people that went into the homes to visit the new moms that just had babies. And so, I don't know how much of those programs are out there now, other than I know WIC programs on the reservations are starting to incorporate parenting classes and any other type of educational stuff that might benefit the parents of new babies. This acronym is very helpful, called NESTS, which focuses on the mother. We want to make sure she's getting good nutrition, she's getting some exercise, even if it's a 10, 15-minute walk, getting proper sleep, that she has time for herself, and support, emotional support, parenting support, respite care, has some adult interaction and peer support, preferably, another woman with the same experience of having just had a baby. The mom's body needs time to recover. So getting some exercise is going to help release serotonin and endorphins, that are those natural feel-good chemicals that are released through exercise. And time away is really important for them to spend some time with themselves to help them get regrounded. I remember my mother and my grandmother were like my saviors, because I remember feeling like I was never going to sleep again. So I used to go to their house during the day and just hand over my baby and go get some sleep and take a shower. And, that's why I say I couldn't have done it without them. So as much support as they can get is really great. Some interventions, some may need pharmacotherapy. Like I said, a short-term dose of SSRI, depression medication, and ECT. This ECT came up, I didn't really read into it anymore. That is pretty intense therapy. Psychoeducation, they need to know about the causes of PPD, the impact of it, importance of their self-care, what treatment options are available, techniques to address scary or unhelpful thoughts, have radical acceptance and mindfulness. Cognitive behavioral therapy is helpful, and bright light therapy. Any kind of depression, a bright light has been shown to be real effective in helping people with that. Some interventions for the parent and infant is, we learn how to parent how we were parented. So sometimes it's realizing how we were parented might not have been the best, and that we need to change some things ourselves. This is working directly with the parent and infant for 16 weeks, observing the parent-child interaction. This could be done directly or using some videos, identifying concerns and worries, identifying the pattern of relating and behaving, supporting the parent to develop different ways to relate to their infant, identify influences from the past that are impeding the parent-infant relationship. Emphasis is placed on parents' internal working models or representations of the infant in the context of their own caregiving history and attachment experiences. So this is what I mean when I say we tend to parent the way we were parented, of like, well, this is what I know and this is what I was taught. So sometimes we need to be open to other ideas. The parent-infant psychotherapy aims not only to learn to identify and meet immediate presenting problems with the baby, but to educate the parent about the relationship and develop a healthy attachment. Help the parent and child feel more positively about themselves and their interaction. And the effects of this can only increase self-esteem, improves the parent-child interaction, reduces parent stress, and reduces parent-infant conflict. When infant side is a very serious when the mother could have some psychotic or psychosis symptoms. You would want to ask these questions. Have you felt irritated by your baby? Have you had significant regrets about having your baby? Does the baby feel like it isn't yours at times? Have you wanted to shake or slap your baby? Do you think the baby or you would be better off if the baby was dead? And do you have thoughts of harming your baby? So these are very serious probing questions that you might not feel comfortable with. So if you can get the medical professional or the psychiatrist involved, that would be helpful to have them there while these questions are being asked. But then depending on what your role is and where you work, it might be something that you refer to have someone do those who's more experienced. Medications, exposure of low doses of antidepressants through breast milk must be juxtaposed with that of untreated. The benefits of breastfeeding for maternal and infant health are well documented. Prozac has higher med levels if prenatally exposed. Citalopram is a newer depressant. Zoloft and Paxil reports of adverse effects. So this has got to be up to the physician to decide what kind of medication will be used that's not going to affect the child, especially if there's breastfeeding involved. Opiates has been a big thing lately because I work in the substance abuse treatment field. You know, some women continue to use opiates or get prescribed them for some reason during their pregnancy. So there could be sudden opioid withdrawal for unborn babies, which can cause respiratory distress, can lead to the fetus not getting enough oxygen, and that can be fatal. Neonatal abstinence syndrome, NAS, refers to the period of withdrawal experienced by newborn babies born to opiate-addicted women. Levels of buprenorphine and methadone levels are low in breast milk, and breastfeeding should be encouraged. So if they're on a MAT program, they can still breastfeed while they're taking those medications. But levels of naltrexone are not as well known. So there was no research that supported if naltrexone is safe. Literature review, like I said, I was doing some research to see what I could find, which wasn't much. Postpartum depression is a common health disorder occurring after birth among women of childbearing age. This affects the mothers, the newborns, and the partners. It affects approximately 13% of new mothers. Of course, that rate is higher with Native Americans. There is a higher prevalence of Indigenous mothers. There should be some tailored programs to and services to prevent postpartum depression in Indigenous groups that could better protect the mental health of mothers. So like that home visiting program I was telling you about, and these WIC programs or parenting programs, when they say tailoring, it's getting I would think getting the elders involved who have knowledge of child caring practices that have been handed down. That's important to look at in making the program more open to Native women that need the services. Some social determinants of health. We'd want to look at historical trauma experiences, inequalities and discrimination. So these are things that can cause postpartum depression that we haven't even thought about, that comes from just being Native American and living in a household with low income and language barriers, not having proper social support after pregnancy, high stress during pregnancy. And a lot of the Indigenous mothers in the research that I read were a lot younger. And that seems to be pretty common in most areas that I've been working with Natives, that it's common that mothers have their children at younger ages than the non-Native people. Also, some of the results from the research is that there's less likely to report cohabitation. So these women are most likely on their own, more likely to have taken antidepressants before they got pregnant. So they had been diagnosed at some time before, have experienced abuse in the past 2 years. So we also need to be looking at what's their safety situation now. Is there some, possible abuse going on? and also lower levels of education to comparison group of non-Indigenous mothers. So these are the things that were found as they ran the data on the women that were identified in some research for PPD, that these are some of the common factors that came up. So there is anxiety for the first-time mom. I've been there, being tired and grouchy, sleep deprived, C-section surgery. I had C-sections myself. I'd see the moms that came in and had natural birth checking out, I swear, the same day, and there I was still in the hospital. Baby blues, the body and house needs to adjust and everything changes. After 2 weeks, extremely sad or irritable, not functioning like you were before. So it's a huge adjustment, very huge. May feel like constant chaos. And then there may be some selfish anxiety, such as how can I be a human being again, just like feeling not yourself anymore. Women that are breastfeeding might feel like they can never leave their baby, even though the baby, you know, it's a wonderful new thing in the family. But to be completely immersed in motherhood can also cause a woman to feel like she's just got lost identity. And then staying home all day and the partner coming home, our family coming home, and they're like, well, what's wrong with you? You've been home all day, you know, like real insensitive to what the person is going through. But they need to be able to carve out some time for themselves. So when you offer that support, like, you know, even as a grandmother at my age, I still every now and then want to get my grandchildren and just give my daughter a break so that she can go do stuff that she wants to do for herself. Because, you know, as a grandma, sometimes it's fun to take care of those kids. Some signs of anxiety would be irrational fears, being irritable, jumpy, feeling paranoid, and sudden mood changes. Like I said, this isn't just postpartum depression. There is also postpartum anxiety, like being scared that they're not doing a good enough job or that they're not capable. So as much classes and learning as they can get, the better off they'll be. Signs of depression, excessive crying, wanting to be alone, isolating themselves, extreme sadness, and feeling shut down, disconnected with the child and everything else. They may be afraid to ask for help. They may deny help, even though they really want it. So even though they're going to deny it, you might just say, I know you're saying you don't want help, but these are some of the things that I'm going to do for you or I'm willing to do for you. But it's just constantly checking on them until they adjust. And from personal experience, I think it takes a couple of months to feel comfortable finally. Some helpful tips for the new mom might be to give her a journal. You can use this journal to see growth and identify red flags and triggers for anxiety or depression that you want to do different. It is a great therapeutic tool. A notebook helps to write it out and get it out. You can write down, you know, who you had the thoughts about or what thoughts you had regarding anything. You could take a stroller, you know, get some fresh air outside, have someone, you know, take the child for a while to give you a break or, you know, take them outside, getting fresh air, you know, now that especially the weather's starting to get a little better here, and distracting yourself and address the situation later. So sometimes, you know, if she's struggling with something, just getting out will help. And putting thoughts aside so that they can try to carve out that time for themselves. And it's the same with anything. You know, if we're helping in the helping profession, we also need to take care of ourselves. So maybe just sharing some of the things we do for ourselves with them is really helpful. So what if you have a friend that you're concerned about? You might want to text them. You might want to call them. You might want to take them a meal. I found this fam group on Facebook, and I think it's a really great Facebook page for new moms. And they also have some really great YouTube videos that I thought were very helpful. They have some new moms on there that share a lot of their own personal experience that I think is really interesting. And I was watching a Grey's Anatomy last night. I don't know who all watches Grey's Anatomy, but there's a couple of new moms that are doctors, and I thought it was kind of hilarious. Of course, they were in a bar, but they were talking about how stressed out they are and how hard it is to be a mom. But when I'm thinking about this, they were able to identify with each other of how hard it is to be a parent and be a medical professional at the same time. As I shared with you, as an Arapaho, I often share, especially when I work with other tribes, I tell them, I might tell them, well, what is your practices here? Like my tribe, these are the things that I was taught. Like I was taught, you stay home for at least 2 months and you keep the baby inside as much as possible, making baby moccasins and letting them wear them until they walk. Everybody wants to buy all these new Nikes and everything. And I made my own baby moccasins and I make them now. I made them for my own grandchildren. So that is a traditional practice, and naming the baby. So that's important. I've run into adolescents and adults in treatment and counseling programs that I really feel just getting that name just really helps them a lot. Like it takes them far. I got my name when I was very young. It was handed down to me through my great grandmother, and her name was Strong Woman, and I was her first great grandchild that was a girl, and she wanted me to have her name. So I'm very honored to have that name because of all the stories that I hear about her. And we also have someone who's well respected carry the baby out of the hospital so that it's supposed to be a good thing. So there's different things that we do. I think another one that I share with my own children is the baby shower and getting ready for the baby. And again, I'm Arapaho, and this is our belief that we don't do all of that stuff until the baby gets here. We wait for them to get here, and then you have your baby shower and get all the things. So you might just get just the basics. Of course, everybody needs diapers and wipes and maybe bottles if you're going to be bottle feeding and things like that. But it's just a cultural belief that we have that we're not supposed to do that. So I just thought I would put some of that in here. And to summarize everything that I covered, postpartum depression affects about 20% of all women. Both mother and partner should be screened for depression symptoms. PPD can begin anytime between 20 weeks gestation and 4 weeks postpartum. Untreated, it can last for years. Scary thoughts are often a part of postpartum depression and should be normalized with parents. PPD prevention involves the nest for both parents, the nutrition, the exercise, the sleep, the time for self and support, and treatments that are helpful would involve psychoeducation and CBT. Certain SSRIs, these are antidepressants, are safe when breastfeeding. You consult your medical doctor on that, or the psychiatrist who's ever prescribing. There are many triggers for postpartum depression, so it's being able to identifying and knowing how to manage those. Women at risk for PPD should engage in early intervention and planning while still pregnant. Encourage family support, support cultural beliefs, and engage elders in teaching new parents about child rearing practices. And that wraps up the presentation for today. Thank you.
Thanks, Avis. That was wonderful. And I look forward to next month's webinar in April when we go over the topic of adult depression. So, okay, I'm gonna push stop and